Hi everyone, this is Dr. Aditya, and today I'm here to shoot a short video that will be talking about outlet forceps delivery. So, today my major focus of this discussion is going to be on outlet forceps, though I have gotten with me one more type of forceps, that is mid pelvic forceps. So, it is going to be a very brief discussion that helps you in your practical exam, especially in your instruments viva. Now, when it comes to the instruments viva, there are a few more videos that I'm making on the same. I have always been of the opinion that you shouldn't really be choosing a very easy instrument like sim speculum or something like an AV retractor. I do believe that if you have read adequately, you can pick up an instrument like a forceps and you can score really well. It, in fact, at the level of undergraduates, even impresses your examiners a lot, and the questions are going to be very specific. So if you do well in it, you tend to score really well in that table viva. So beginning is what is outlet forceps delivery? Outlet forceps delivery, or just forceps delivery, first of all, is a type of instrumental vaginal delivery. It's a type of assisted vaginal delivery. Basically, it's a vaginal delivery, but it is being assisted by an instrument. So we have two major instruments that we have. First one is a forceps and the other one is a vacuum. There's also a vacuum that I have gotten with me over here. So this is a vacuum and the other one is a forceps. So these are the two different types of instrumental or assisted vaginal deliveries. Of them, one of the most important ones, yet one that not a lot of residency program students are able to use accurately, and something that I believe that obstetricians are nowadays just letting go of this instrument. The older ones definitely advocate the use of forceps, and I am personally a big fan of forceps. But then the backside of it is that the downside, the shortcomings are that it can lead to terrible perineal lacerations. I have even seen a couple of maternal mortalities because of traumatic postpartum hemorrhage that these pair of forceps have caused. So if you're good enough, I would definitely recommend that you go ahead with it, because doing a cesarean section in second stage, there's a video that is coming on this as well, is quite risky. It has its own drawbacks. So this provides a very useful and a great alternative to do the same. So I've gotten a few pairs of forceps for you. This is one, this is the other one, and there is one more over here. So I've gotten three pairs. What I've not been able to procure is a Piper's forceps, that is basically one that we use for the aftercoming head in breech presentation. So to begin off with, I would want to choose the simplest one and the most common one that you shall probably get in your exam. That is going to be this outlet forceps. Now I just added the word outlet to it. What is outlet? Now we all know that the fetal head station is given a position from -5 to 0 and then 0 to +5. So anything wherein you can see the fetal head through the perineum, so probably the station is +4 or +5. In that scenario, you should be using an outlet forceps. Outlet forceps, several types, something like Simpson's forceps or Wrigley's forceps are a definitive way of using your outlet forceps. They are a type of outlet forceps. Low forceps is anything that is from +2 station till +5, whereas from +1 and 0 it is going to be mid pelvic forceps, or what we also call as a rotation forceps or the Keelan's forceps. So first, I would like to tell you that the skill that you all need to know, the skill that you all need to inculcate is definitely the one wherein you can use an outlet or a low forceps well. Rotational or Keelan's forceps is a very specific skill set that not a lot of people use today, but at least this is something that you should know in your clinical practice. So with me right now, I have a Simpson's forceps. In your exams, you may as well get a very similar instrument, but of a much shorter length. It will be probably only this much of the original length, only this much, and ये भी इतना जो इसके नीचे का handles. I'll be telling you what we call these things, each of these parts. So you might get something that is much smaller. That will be the Wrigley's forceps, but again, that is going to be a type of outlet or low forceps itself. So here I have two branches. We call these individual branches of forceps. In each of these forceps, I would like to show you the parts. This is the place where the head is trapped of the fetus. यहाँ पे head अटकता है, यहाँ पे इसके बीच में. So as you can see, this inner side that you can see, this curve, the entire thing is called as the cephalic curve. I say cephalic because the head is what is going to be trapped inside this. If this is a fetal head, that is going to be trapped inside this. Similarly, if you see it from sideways, you would see that there is a certain curve. You can see this curve that you can see. Yes. So this curve is your pelvic curve. A lot of people think that this is your pelvic curve. No, this is not your pelvic curve. Your pelvic curve is going to be this, because this is what goes onto the sacrum and we pull out the baby like this. So this is your pelvic curve that goes along the angle of Caris, that is basically your sacral angle. So हम लोग ऐसे डालेंगे और ऐसे निकालेंगे. So this is your pelvic curve, and this inside is going to be your cephalic curve. So when I talk of this pair of forceps, there are a few parts to it as well. This is your toe. This tip is called as a toe. This over here is called as the heel. This one. This is the heel of the forceps. These are the two major parts of the forceps wherein we hold the baby. Over here, this is the shank. Now the shank is what gives you length. The shank is the longest in Piper's forceps. In Piper's forceps, wherein you need to deliver the aftercoming head of breech, this area, this length is going to be much longer. It is literally going to be this long. Over here, you have your lock. What you can see this over here, जो मैं भी unlock करूँगा. So this is your lock that is there over here. This is a type of English lock. What I have with me, a similar forceps, but you can see this lock. This is a German lock. Basically इसको मैं घुमाता हूँ. When I move this, it becomes loose. When I इसे loose होता है और ये निकल सकता है. If I put it back again and I tighten it, this can become tight यहाँ पे ऐसे लगा के. So this is a German lock. One more type of lock that we have today is with the keel end forceps, and that over here you can see is the sliding lock. The use of sliding is this, you see. So this is a type of sliding lock, as you can see over here. So what is the way in which I apply? An outlet forceps, first of all, before you start applying, you need to know that there are a few prerequisites that have to be fulfilled, and before those prerequisites, you should know what are the indications, what are the reasons for which I should be using a forceps. So the biggest reason for which we need to use a forceps is going to be fetal distress in second stage of labor. So if there is fetal bradycardia or fetal tachycardia, mostly bradycardia, and you immediately need to deliver the baby, at that point of time you can use a forceps. The other one is when maternal bearing down is contraindicated. Now what is contraindicated maternal bearing down? Very easy thing. Basically, whenever a female is bearing down, when she is fully dilated, when she is trying to strain, at that point of time, whenever she is trying to strain, at that point of time she is doing Valsalva maneuver. Now whenever she is doing Valsalva maneuver, there are several changes that take place in the cardiac system, in the venous system of the venous return, preload and afterload of the heart. These hemodynamic changes, that is something that I have spoken in the heart disease, the chapter on heart disease, the case discussion that we are going to have on heart disease. I have spoken about Valsalva and each of its effects, mal effects on the mother. So in women in whom you cannot be asking her to bear down, the women who have heart disease, especially with severe mitral stenosis or severe aortic stenosis, wherein I cannot let the female be in a stage of bearing down, so I have to cut down her second stage of labor. Second stage of labor is where the cervix is fully dilated and the head is yet to deliver. So in that scenario, I quickly need to remove the baby. In that scenario also, I shall be using a forceps. Apart from that, if there is delayed or arrest of second stage, wherein basically the head has come into the second stage, the cervix has dilated completely, the head is probably at +2, +3 station, but it's been an hour or two depending on whether she's a primigravida or a multigravida and she has not yet delivered. So in that scenario, she has had an arrest, or basically the baby is stuck in the second stage, then I need to expedite the delivery by using this. So this, and lastly, if the mother is way too tired, if she's exhausted, or the mother is not conscious, or she's having an altered sensorium, probably a female who has had eclampsia and is not bearing down, or an unconscious female, or a female who has had a hemorrhagic stroke because of hypertension and she is paralyzed, she's just not able to listen to any commands. So in that scenario as well, she cannot bear down, and hence in patients who are exhausted or are unable to take commands, in them as well you should be using a forceps. So these are all the indications. Contraindications, obviously, first of all, is lack of expertise. If you don't know, if you have never applied, never used this can be a very dangerous instrument. If you are trying it without expertise available, it can lead to torrential tears, it can lead to fetal injuries, and the outcomes will be very disastrous. It is going to be very difficult to suture those genital lacerations. Other contraindications to the use of this include anything that contraindicates vaginal delivery. That includes if there are any genital warts that she has, or something like wherein vaginal delivery cannot be done, like cephalopelvic disproportion. If the pelvic outlet is not adequate enough, in that scenario you cannot be using this. So these are a few contraindications. So now that we are done talking about the indications and contraindications, I shall talk about what are the prerequisites. So once you have seen that this female is fulfilling an indication, let's say that I have to apply it because the baby is having distress. So I need to weigh the options if doing a vaginal instrumental delivery is going to be better than doing a second stage cesarean section, and if you have the available expertise, then definitely go ahead with it. Now that I've decided indication has been tick marked, indication fulfill हो गया है, now I have to look कि क्या क्या ensure करना है before I start using this. So there are a few prerequisites. There are maternal prerequisites, there are fetal prerequisites. In the maternal prerequisites, the first thing that you need to ensure is that her bladder has been completely emptied. So ensure that the bladder is emptied. Put in a Foley's if you want, or just put in a red rubber tube catheter and empty the empty the bladder. Secondly, adequate analgesia. You need to give proper analgesia. For that analgesia, you can either give a usual perineal block that you give during episiotomy using a local, or you might have already given her epidural anesthesia. So yes, ensure that adequate analgesia is given, because this can be a painful process and the female may not help you by cooperating with you if adequate analgesia is not given. Apart from that, you need to ensure what is her cervical status. So cervical status should be fully dilated and the membranes have to be ruptured and they have to be absent. So that is the biggest prerequisite. When I come to the fetal requisites, at that point of time I need to ensure that it is in cephalic presentation. सबसे बड़ा है, अगर breech में है तो only for the after coming head I can use it, but that's a very rare indication. Mostly it has to be in cephalic position. You also need to remember कि कोई mal presentation या deflexed head ऐसा ना है, तो you have to ensure that the position of occiput is something that you know. Preferably the position of occiput should be either left or right occipito anterior or occipito anterior or occipito posterior. In transverse position, never use an outlet forceps. At that point of time, you need to use a rotational Keelands forceps to be able to rotate the baby. Apart from that, you need to know whether the baby has any mineralization disorder, something like skeletal dysplasia or some ossification disorders, wherein if you're going to apply this can end up crushing the fetal head. So all these things need to be ruled out. So once you're sure of this, all the prerequisites are fulfilled, everything has been tick marked, then you go ahead and you apply. So how do you apply it? So first of all, I'm going to have just these two blades. I'm going to bring them together. I'm going to arrange them. Now how do I arrange them? Is there any way to know how to arrange them? So सबसे पहले तो तुम्हें देखना है कि जो तुम्हारे पास जो दो दिए गए हैं ऐसे, उसमें ये pelvic curve कहाँ पे है. So यहाँ पे दिख रहा है pelvic curve. This is the pelvic curve. The above one is the ऊपर का curve. This is the pelvic curve. So keep this ऐसे, and then you have to remember कि इसको ये जो concave side है, this has to be medial. And take the second one as well. Second one का भी देखना है, ये pelvic curve नीचे वाला है. You cannot be holding it this way उल्टा. It has to be this way. So hold it this way and then bring it facing over here. When I bring it to face over here, I can easily find. So सबसे पहले the trick is to know where the pelvic curve is, so that you can arrange both your forceps along that direction and then check how can they be facing each other ऐसे to make this cephalic curve complete. So पहले pelvic curve को पहचानो and then recognize the cephalic curve. Once that is done, this is called as the phantom application. This is what is to be done before applying the forceps inside the mother's pelvis. This is called as phantom application, which I do outside her pelvis. Once I'm done with this, I remove it. First of all, I see which is the left branch. So this is going to be my left branch, as I know ये ऐसे अंदर जाएगा. So I'm going to hold it in a pen holding fashion, literally like this. A few people hold it like this. This is not the grip, neither is this the grip. This is going to be the grip with your 3 fingers. ऐसे पकड़ना है. That's it. ऐसे बस पकड़ना है. You see that the direction has to be facing like this. Then I take 2 of my fingers and I put it in the vagina. Once I put them on the vagina, my thumb is raised in 90 degree ऐसे. So once it is inside, I shall be placing the toe on my tip. I'm showing you from sideways as well. ऐसे पकड़ना है and then धीरे धीरे ऐसे अंदर slip करना है. This thumb is to be placed over here at the heel to be able to maneuver it and to push it ahead. So once I am done pushing it into the posterior fornix, then I am going to slide my hands आगे and I am going to rotate it sideways. How am I going to rotate it? आगे से देखो, ये मैंने ऐसे डाल दिया था. Now I am going to rotate it on its axis. And once it has been rotated along its axis, remember the movement is rotational. मैं पूरा ऐसे नहीं घुमा रहा हूँ. I'm just rotating. Look at my fingers of this hand, of my hand with wherein there is a watch. I'm just rotating it like this, and this is how I shall be placing it on the left side of the maternal pelvis. Once I'm done doing this, I will ask my assistant to hold this tightly and to stabilize it over here. Now that this has been applied, assuming that an assistant is holding this for me, I take the right side forceps and I hold it again in the same fashion. I hold it this way. I then insert my left hand inside similar way में ऐसे मैं डालूंगा इसको अंदर and I shall maneuver it, and then again I shall rotate it, and once I have rotated it, I shall ask the assistant to give me the forceps and then I shall lock it, and this is how I shall be locking it. The locking has to be complete, it has to be fulfilled. You need to see that the lock is complete and there is no significant gap in between them. The locking has to be comfortable. Once the locking has been done, then there are two things that I need to ensure now. First of all, I need to know कि मैंने attach किया है, then this has been locked comfortably. Secondly, at the peak of contraction, basically whenever the contraction of the uterus is at its maximum, at that point of time I will ask my assistant to just keep this upper and I'll be giving an episiotomy, or I pull this slightly upwards and then I give an episiotomy. Now there are a few people who say that you should be giving an episiotomy before putting the forceps. I do not believe that, because I believe that whenever I'm putting these forceps ek ek karke, that episiotomy can extend inward. So I prefer putting in the forceps first and then giving an episiotomy. At the moment that she gets a contraction, I shall be giving an episiotomy. And then there are two methods. The ideal method is to hold it this way. Remember that there are Simpsons का ये एक वे है पहचाने का, इसको ये दो रहेंगे ऐसे बाजू में, रिगलीस को ये दो नहीं रहेंगे. This is to place my fingers. यहाँ पे ऐसे रख के you have to pull it outwards and बाहर. Sideways से अगर देखोगे तो बेबी का हेड यहाँ पे था, I pull the baby बाहर ऐसे. Now depending on the station, now remember this is basically the sacral curve and इसके ऊपर ये मैंने place किया है. If it is +2, then I need to first pull it downwards, whereas if it is +3 या +4 या फिर +5, then all I have to do is I have to pull it outwards and upwards. So basically if it is too much inside, then I have to first pull it downwards, then outwards and upwards. But again, if it is at +2 station, then पहले नीचे खींचूंगा, फिर सामने and then ऊपर. Whereas if the station would have been something like +4 or +5, then I would have just pulled it forwards and upwards or outwards and upwards. So this नीचे वाला movement is only if the station is +2 or +3. कि ऐसे नीचे खींचता हूँ and then मैं बाहर खींच के ऊपर खींचता हूँ. Whereas if the head is, whereas if this is a proper outlet forceps wherein the station is at +4 or +5, then it is just pulling it outwards and upwards. Once I'm done doing this, the head has been delivered out, then I shall unlock them, I shall put them aside, then I shall be delivering the entire fetus. Once the entire fetus has been delivered, remember placenta सब expel होने के बाद में you have to do a rectal examination, put in a finger inside the rectum, inside the anus and check if there are any rectal tears. Do a cervical tracing to know whether there are any cervical tears and also see if there are any vaginal lacerations, and then suture it under local anesthesia using any absorbable material. So that is it about outlet forceps. एक ही मेथड था ये ऐसे डालने का. I would want to also show you the Keeland's forceps. Now ये Keeland's forceps दिख रहा है. This is called as a rotational forceps. Why do we call them the rotational forceps? Because it helps to rotate the baby and to bring the fetal position from occipital transverse to occipital anterior. Now see, there's a distinct difference. इन दोनों के shanks देखो. Compare the length first of all. The length of this is quite long. So this is one of the longer forceps. You can see it very easily. तो इसका ज़्यादा लॉन्ग है because this is used for mid pelvis forceps. दिस इज एन आउटलेट फॉरसेप्स wherein the baby is quite outside, but इसका शैंक बड़ा है क्योंकि बेबी का हेड काफ़ी ऊपर है. द स्टेशन इज एट 0 और +1. देन remember and also see the shank. यहाँ पे the shanks are parallel to each other whereas they are riding over here. Parallel to each other, riding over each other. दिख रहा है एक दूसरे के ऊपर राइड कर रहे हैं वो. This riding is to ensure that they do not occupy maximum space in the pelvis and you can do a rotational movement and rotate the baby. इसमें रोटेट करना वुड हैव बीन अ वेरी डिफिकल्ट अफेयर बिकॉज इतना डिस्टेंस है इनके बीच में. So how do I insert this? Something that you don't need to know at an undergraduate level, but I'll still teach you all. सबसे पहले लेना है मुझे ये वाला जो लेफ्ट साइड का है. देर आर मल्टीपल मेथड्स ऑफ डूइंग इट. आई कैन ईदर इंसर्ट इन द वे आई इंसर्टेड यहाँ पे कि मैंने पोस्टीरियरली डाला और फिर घुमाया, जिसको हम लोग वॉन्डरिंग मेथड कहते हैं. या फिर आई कैन ऑल्सो डू कि मैं इसको ऐसे पकड़ के ऐसे ऊपर डालूंगा. दिस इज द प्यूबिक सिम्फिसिस. जस्ट गिव मी अ सेकेंड, आई विल शो यू यूजिंग अ पेल्विस एज वेल. So over here I have gotten a pelvis. You can see this is a pelvis. So now there is one method of inserting this. Now this is that female's pelvis that she is lying down. Now there are two methods of inserting this. Remember, this is your pelvic outlet over here. You can see this is your pelvic outlet. So there are two methods. The first method, as I mentioned, मैंने नीचे से डाला and then ऐसा घुमाया और ये साइड लेके आया. Or if you want to see from here, I inserted it this way and then I rotated it sideways. The other way is इसको ऊपर से ऐसा डाला मैंने एंड देन आई रोटेटेड इट. ऐसे नीचे आई रोटेटेड इट टू शो यू अगेन. सामने से आई इंसर्टेड इट दिस वे एंड देन आई रोटेटेड इट. एंड ये ऐसा रोटेट करने के बाद में मैंने पीछे वाला लगाया एंड देन मैंने उसको घुमा के बेबी को सीधा किया. सो दिस इज ऑल्सो नोन एज द क्लासिकल मेथड. whereas if I'm going to show you how I did this, यहाँ पे सबसे पहले मैंने यहाँ से नीचे से डाला था like this and then I had rotated it and I had asked the assistant to hold it. Then I took this one, the right side forceps, I rotated it like this and I asked my assistant to again hold it. Then I locked both the forceps. I locked both the forceps like this यहाँ पे. And then if the station was quite ऊपर, then मैंने पहले नीचे लाया बेबी को and then ऊपर निकाला. Whereas if the station was quite outside, then I just had to pull it outwards and upwards. अगर बहुत अंदर है तो पहले नीचे खींचा and upwards and outwards. Basically this angle of Caras, this angle that you see, this one, this angle, this is where the gliding happens. So अगर station बहुत ही ऊपर रहेगा, I have to first pull it downwards and then I can pull it up. So the angle of Caras जिसके ऊपर pelvic curve बैठता है, you can see the pelvic curve is going on the angle of Caras, this one. So that is how I deliver a baby with forceps. And this was your Keeland's forceps. Okay, you would ask me what is the use of this sliding. The sliding is going to help me in correcting asynclitism as well. अगर sideways मुझे lateral flexion ऐसा head का कराना है बेबी का, उसके लिए ये फायदे का है. So that is it about the session on forceps. I hope you all understood this session. I shall be doing a separate session on vacuum. I shall be continuing it with this session itself, but it will be uploaded separately. So that is it from my end. This is Dr. Aditya signing off. Keep watching AN OBGY Masterclass.